Welcome to the Lyme Epidemic webinar, sponsored by the Howard County Lyme Awareness Group. My name is Candace Dickover from the Howard County Lyme Awareness Group, and I will be the facilitator for today's session. A little bit about myself. I founded the Howard County Lyme Awareness Group here in Columbia, Maryland. It was in response to not only suffering from Lyme disease and unfortunately too little treatment from my initial bite in 2007, but also from watching my entire family of 4 go through this debilitating disease along with other co-infections. The mission of our group is to promote advocacy and awareness to the general public, as well as to provide outreach and support to Lyme disease sufferers and their family members. We also try to provide a message of hope and let people know they're not alone. Okay, Kathy, do you want to advance to the Lyme doesn't discriminate? That's one thing that I mentioned in promoting this webinar. It certainly doesn't. Ticks don't mind if you are old or young, if you're athletic or in poor health. It doesn't matter if you're rich and famous or you're poor. There are 300,000 new cases of Lyme disease each year in the US, and more than 500,000 Americans suffering from long-term or late-stage Lyme disease. Some of them are fortunate to be diagnosed and treated early, but for some the path to a cure is long and challenging. Tonight, we're privileged to have Dr. Kathy Spreen here to educate us about Lyme and other tick-borne illnesses. With that, I'd like to welcome Dr. Spreen.
Thank you all for listening this evening. I'd like to wish you a good evening. We're scheduled to have some thunderstorms here where I'm sitting, but hopefully that will wait until after the program is finished. I'd also like to thank Candace for organizing what will hopefully be a very informative session. Now, who am I and what qualifies me to be here speaking to you this evening? I am a physician. I'm specialty board certified in both family medicine and in preventive medicine. I have master's degrees in public health and in biochemistry and research methods. I am a medical writer, and I have managed dozens of professional writers and editors over the years, and I have been a ghostwriter for peer-reviewed journals, for dozens and dozens of journals. At one gastrointestinal international meeting, we had over 120 publications just for that one meeting. The point here is that most of the medical literature that you read is not necessarily written by the person whose name is under the title. It's written by ghostwriters, people like me and my teams, who put these things together. I was in the pharmaceutical industry for a number of years, and my job was to function as a medical monitor. That meant that I was the physician overseeing clinical research trials internationally. And I worked in many different therapeutic areas. And the reason that I mention this is that Lyme is a disease that affects essentially all body systems. And if you just look at Lyme disease through a dermatologist's eyes, you're going to miss things. If you just look at Lyme through a rheumatology perspective, you're going to miss things. If you're only looking as an infectious disease specialist or an endocrinologist or a psychiatrist, you're going to miss things. So because I worked in so many therapeutic areas, I felt that I had the experience to put a lot of these ideas together in a book that I eventually wrote about Lyme disease. I am a Lyme patient, and I am a Lyme caretaker. My husband had Lyme disease. I had my knee replaced due to Lyme disease. But the most motivating factor was when my son became so sick with tick-borne illnesses that I didn't think he was going to survive. And there's nothing more motivating to a person than to see their child be so sick and to be helpless to do anything to help them. So why did I write a book? Because when my son was so sick that I thought he was going to die, none of the half-dozen physicians that he saw initially, including me, had any idea how to help him or what was wrong with him. And I wrote a book because I didn't want other families to have to go through the hell that we went through in trying to get appropriate care for our child. I wrote the book that I wish I had when my son first got sick. Just to give you a little bit of background, about 5 years ago, my son was about 20 years old. He had a deer tick attached to his flank. He started to feel exhausted and achy, and within a few hours, he had a 6-inch by 4-inch solid maroon oval rash. And at that point, I was one of those physicians who didn't think Lyme disease was a very big deal. So I told him, let's just wait and see what happens. Well, he got sicker and sicker. We finally took him to the family doctor, who said, well, this couldn't be Lyme disease because his rash isn't round enough. But since he's so sick, we'll start him on a little bit of low-dose doxycycline. And that doctor and me, we both felt that a little doxycycline and he should be fine in a few days. We took about 4 doses and he was doing better until he just crashed. And I really thought that my son was dying. He had 106-degree fever. He had rigors. Rigors are shaking chills that are so bad it looks like you're seizing. He had soaking sweats. We had to change the bed linens every couple of hours. He was delirious. He became unconscious, and I couldn't rouse him. Finally got him to the emergency room, where what I later learned is part of the Lyme debate that happens so often when Lyme patients go into the emergency room. I was told that he did have Lyme because Lyme can cause fevers of 106 degrees. Well, not usually. That's probably a co-infection that caused that. The doctor agreed that we did have a deer tick in a jar, and that the family doctor had started him on doxycycline, so he must have had a reason to do that. But that same doctor also said he could not possibly have Lyme disease because the rash is not round enough, and the rash is not shaped like a target or a bullseye. It was too maroon. It should just be red. His tick was not attached for 24 or more hours, and I'll get into more of why that is an unreasonable assumption in a minute. He had too many monocytes in his blood count and not enough neutrophils. The bottom line was, the doctor said, we should be grateful that he's being treated for the Lyme disease that he most certainly does not have. So he left the emergency room just as sick as when he came in. Fortunately, through a local Lyme disease support group, we found a doctor who didn't know about Lyme disease and co-infections, and treated my son aggressively for 6 months and essentially saved his life. Now, in retrospect, what I didn't know then that I do know now, he did have Lyme disease, which was confirmed by various blood tests, including blood culture. He also had, and probably still has, Babesia, Ehrlichia, and Bartonella. Lyme is very difficult to diagnose alone. When you have concurrent co-infections, it can really complicate the diagnosis and treatment. As I studied, when I was trying to get help for my son, The problem wasn't that there wasn't enough information, but there was too much information. And unfortunately, much of this information was confusing and contradictory, complicated, and just not in line with what I was observing in real life. What I learned from my son's experience was that there are many things as a physician that I do not know. There are many things that other doctors don't know. There are many facts that I accepted as true that had no science to support them, and that doctor-patient miscommunication can put both parties at risk. We all have a lot to learn about Lyme disease. So let's talk a little bit about this illness, and hopefully from what we learn we can make better decisions about how to manage our problems as we move forward. This slide shows the spirochetal form of the bacteria that causes Lyme disease. The genus of this bacteria is called Borrelia. The species is called Burgdorferi. This is a dark field slide so that you can see the spirochetes. They're shaped like little spirals or corkscrews. This is one kind of life form that they have. When these spirochetes are floating around, free-floating in the blood, this is usually when the patient experiences the symptoms that we associate with Lyme disease. But as I will mention briefly later on, the Lyme bacteria has a number of different kinds of life forms. The spirochete is one, and then it also has dormant forms, forms that can insist and form biofilms. In 2014, at Oregon State University, a team of researchers there found this same Borrelia burgdorferi that causes Lyme disease in amber that's 15 to 20 million years old. They found this in the Dominican Republic. Also, the Borrelia burgdorferi organism was found in a mummy called Otzi. The mummy is 5,300 years old. It was uncovered in the Alps. Now, Otzi did have arthritis and some other issues that could potentially have been due to Lyme disease, but he didn't die from Lyme disease, although people do. He was shot by an arrow, and that's what killed him. But just because we didn't recognize Lyme disease or call it Lyme disease until very recently doesn't mean it wasn't around. Now, this is a very busy slide. I'll go through it step by step, but it's important in laying the foundation for understanding this disease. As I mentioned, Lyme is caused by a bacteria, a spirochete, called Borrelia burgdorferi. It can affect essentially any body system, and it does this by passing through what are called endothelial cells. Endothelial cells are the cells that line all the blood vessels of the body, the arteries, the veins, and the capillaries. So essentially, anywhere that a red blood cell can go, which are very tiny things, a Borrelia burgdorferi can go. Lyme disease can wax and wane. That means it can come and go, it can flare and remit. And this type of presentation can be explained by its very complicated pathophysiology. Unfortunately, I don't have time to go through all that this evening, but just trust me that the organism, the spirochetes, float around in the blood causing the symptoms, but it can also penetrate down into the tissue. When it penetrates into the tissue, it can be in the form of what's called an L form. L forms do not have cell walls. So if you don't have a cell wall, you can't be destroyed by a cell wall antibiotic that might actually hit the spirochete that's causing the symptoms. So these organisms tend to burrow down into tissues, especially those tissues that have a lot of collagen. What are those? Nerves, brain, joints, skin, heart, kidney, endocrine glands, gastrointestinal organs. They can burrow down in there. They can become dormant. So if you just give the patient something like a doxycycline or an amoxicillin that hits only cell wall organisms, you're going to miss all those organisms without a cell wall that are buried deep down inside. Lyme disease affects susceptible populations. If you look at all patients that we know that have been infected by Lyme disease, and these numbers are all very soft because they haven't been recording the actual number of cases very well and haven't been keeping track of how sick people are and defining very well the parameters of the disease. But if you look at all patients that we have a pretty good idea of, maybe about 50% of these patients get well after a limited illness, sometimes just being treated with doxycycline, perhaps even not being treated. Maybe half get well and they're never bothered by Lyme disease again. But maybe 30 to 40% of patients have ongoing, persistent problems. And these can be accompanied by varying degrees of incapacity. And maybe 10% of Lyme patients are totally debilitated. They have difficulty performing their usual activities of daily living, and they can be significantly impaired so that they have trouble going to school or going to work. Lyme disease can be very hard to diagnose. It is frequently misdiagnosed or mistaken for other conditions. Now, Lyme is also known to persist in a significant subpopulation of patients. Now, who does it persist in? We're not entirely sure why some people get so sick and other people get well after a limited problem. The differences could be due to genetics. Some people just have inherent susceptibility to more severe presentations of Lyme disease. It could also be due to the strain of Lyme that you were infected with. Some strains affect the brain tissue more, some the joints, some the heart. It could be a combination of these factors. It could also be the status of the patient's health at the time that they were infected. It could be the status of the immune system at the time of the infection. These diseases have only been recognized very recently. So we don't have a very good database in what makes some people more susceptible than others, but we are learning. And recent work out of Johns Hopkins and out of Stanford show that there are differences in certain white cell counts in patients with persistent symptoms of Lyme compared to those who are infected but don't have these ongoing symptoms.
Oh, excuse me, Dr. Spreen.
Yes.
I'm sorry to jump in. It seems that some are having a technological difficulty and some people cannot see your screen. Can you go to the upper right-hand corner and press, there's a button that says show my screen?
I think I see that. I should just click on that?
Yes. And then if someone can type in the question box and let me know if you can see Dr. Spreen's screen now. It should say, why is this Lyme bug so persistent?
Just tell me, Candace, when I should start speaking again.
Go ahead. Go ahead and go start speaking, and I'll let you know if anything changes.
Okay. So why is the Lyme bug so persistent? Well, In the book, I have probably 20 pages outlining in detail why it's so persistent. But just briefly, so that you have an understanding of what we're dealing with here. The Borrelia burgdorferi has a very complex genetic structure. It's very highly evolved to survive. It can impact the host's immune system, and it can incorporate parts of their genes into the host's genetic material. The organisms can form cysts, that they can go dormant, they can develop those L forms without cell walls that I told you about, that can make it very hard for them to be treated if the doctor's just using a single antibiotic like doxycycline instead of combination therapy. The organisms can dive and burrow into protective niches. They can hide intracellularly. They burrow into viscous fluids, and those are thick fluids, like those found in the eyeball. There's lots of eye symptoms associated with Lyme disease. They can burrow into the viscous fluids around joints. We know that there's a lot of joint problems associated with Lyme disease. They can resist antibiotics by ejecting them. They can cloak, they can clone, they can change their outer surface proteins, and they can pass barriers like the blood-brain barrier and the placental barrier that a number of other organisms may not be able to pass. And they can also do what is called forming biofilms. Oh, now I can't advance the slide. Let me see what's happening here. Candace?
Yes.
I can't now advance the slide.
Okay.
So whatever I did to show other people the slides has now sort of backfired.
Okay. Hold on just a moment and we'll just fix that issue.
Okay.
So I'm going to take over the slides and you just let me know. Let me know when to switch them.
Okay.
All right.
Okay, so biofilms will form and cysts will form when the conditions are determined to be hostile to the Borrelia bacteria. And hostile conditions include not enough food, if things become too crowded, if there's not adequate oxygen, if there are unfavorable temperatures, or if antibiotics are perceived to be floating around in the bloodstream. And what a biofilm is a sac made out of mucopolysaccharides that can encompass a group of these organisms. And we're most familiar with biofilms because they're the stuff that the dentist scrapes off of our teeth. They can't just be brushed off. These are tough mucopolysaccharides that adhere to the teeth and gums. They also can adhere to the heart valve and in parts of the kidneys. Now, the biofilms protect these microbes inside the sacs, and so they aren't easily hit by antibiotics that we're trying to use against them or by the good immune cells that have come to destroy them. The biofilms, the pathogens within them, seem to have a kind of internal biochemical communication so that they can perceive that when the coast is clear, for example, when the antibiotic is stopped, they can reemerge, and this can be associated with a flare of the Lyme symptoms. We know that biofilms are associated now, and we're just starting to learn about these in the last decade. They're associated with systemic inflammation and are associated with things like diabetes, heart problems, and kidney disease. Now, both the CDC and the National Institutes of Health believe that cysts and biofilms might be largely responsible for much chronic disease. So the fact that the Lyme bacteria can form these biofilms can explain a lot in terms of why they're so hard to treat and why we struggle so much in finding the right combination of antibiotics and other modalities to treat them. Oh, please advance the slide, Candace. Now this is a picture of biofilms. This work was done by Eva Sappi at the University of New Haven. As you can see on the left, hope you can see, you can still see the spirochetal forms there in the first couple of days. Not very well organized, but as you move through the first week, on days 3 to 6, the organisms are starting to coalesce. You see less of the individual spirochetes and more of a cohesive unit there. At the end of the first week to the third week, this is a very well organized biofilm, and it is of the Borrelia burgdorferi pathogen that causes Lyme disease. Next slide, please. Why are the Borrelia so hard to identify? Lots of people go in clearly having symptoms of Lyme disease and all the history that goes along with it. And why are they so often told that they don't have Lyme disease? Well, if you take a sample of, say, spinal fluid or urine or other kinds of tissue that you're hoping to grow Lyme on, if you take that sample and smear it on a slide and put it under a regular light microscope, you're not going to see many Borrelia. You need dark-field microscopy in order to see them. Also, they don't grow easily on routine cultures. If you're looking at urine, for example, and you just smear it on the slide that you usually smear to find the E. coli that usually causes urinary tract infections, you're not going to grow a whole lot of Borrelia. This is an extremely finicky organism. It needs special media. It needs the right temperatures, the right oxygen levels, the right pressures. So if you grow them in a routine lab cultures, like we do for the usual suspects at the local hospitals, you're not going to find them. You're going to have negative tests. You can't find what you're not looking for. If you're not using some of these more specific testing methods, you're not going to find them. People often try to do biopsies of the rash to identify the Borrelia. They, of course, try to go to the part that they think might be most infected, but you have to biopsy the edge of the lesion in order to get the cultures to grow the Borrelia. In my opinion, blood cultures or cultures of the biopsy tissue are the best way to find these organisms, but it has to be done by a lab who knows how to grow them under the special circumstances that are required. Next slide. Now, what is Lyme disease in terms of signs and symptoms. The word pathognomonic means that it can't be anything else. If you see a certain sign or symptom and it's said to be pathognomonic of a condition, it can't be anything but that condition. And in this case, the erythema migrans rash, also called a bullseye rash or target lesion, is pathognomonic for Lyme disease. In my opinion, if you see this kind of rash, you have Lyme disease or a very similar Borrelia-caused disease. Other signs and symptoms that are distinctive for Lyme are the migrating joint pain. First the shoulder will hurt, then the knee will hurt, then the wrist might hurt, the neck might hurt. It's migrating. It's not just the knee or the shoulder hurting. It tends to move around. Numbness and tingling, very distinctive for Lyme disease. Twitching. Bell's palsy. Bell's palsy is a paralysis of the seventh cranial nerve, which is called the facial nerve. It causes drooping of one side of the face. It's usually one-sided. It can have problems with tearing, with salivation, and with blinking of the eye. When people used to come into the emergency rooms where I worked with Bell's palsy, we would tell them we had no idea what was causing it. We would patch their eye since they couldn't blink it, and we'd give them some eye patch and some eye gel and tell them to keep patching their eye so it doesn't dry out, and hopefully they would get better at some point. Also, hypersensitivity is a distinctive feature of Lyme disease. And what I mean by this is that often patients with Lyme become very sensitive to things like light, sound, taste, smell. Children will not want to wear clothes because it's their skin is too sensitive. People will not want to listen to music. They will want the lights turned down. They will put on sunglasses. They are just extremely sensitive to sensory input. Next slide, please. There are a number of things that are very common presentations of Lyme. Probably the most common is a flu-like syndrome. And often Lyme disease is misdiagnosed as the flu or a cold or a gastrointestinal bug. So the flu-like problems with the aches and the fever, very common in Lyme disease. Intractable fatigue. Now, we all get tired when we get sick, but the kind of fatigue that accompanies Lyme disease is what I call intractable, because it does not respond to rest. And this kind of fatigue can be crippling. Some patients don't have the energy to sit up. Many are bedridden. They can't get themselves to and from the bathroom. They can't perform their activities of daily living. Many people describe it as a deflating or a wilting. The person can be standing 1 minute and just totally collapse the next. And very often they're just too tired to function. Brain fog is very common. Pain, especially headache, irritability, joint pain, anxiety, cracking neck and joints, very common in Lyme disease. Next slide, please. Now, things that are frequently observed in Lyme disease, and some of these I will go over in more detail in just a minute. Gastroesophageal reflux disease, reflux or GERD, very common in Lyme. Eye problems, much more common than I ever expected. But when I go to speak to large groups of people, I'm always impressed with how many eye problems that people present with. And some people have lost vision almost completely until they are appropriately treated. One of the reasons this happens is because the Lyme can affect the optic nerve, just like it can affect the facial nerve, and also that thick fluid inside the eyeball is the type of fluid that Lyme gravitates to and likes to set up nice little colonies of the pathogen. Now, neuropsychiatric symptoms, I'm going to go into that in much more detail. Cognitive deficits, memory issues, processing problems. The person might be able to hear what you're saying, but not understand what the words mean. Poor sensory integration. Many Lyme patients can't filter out some of the sensory stimuli. What happens is, as you're sitting there listening to me speak, you may be looking at the slide, you may be hearing my voice, but what's happening is, if you're healthy, you're filtering out a whole lot of other stimuli. The temperature in the room, the softness of your chair, the amount of humidity, background noises, all those kinds of things. In many cases, if you can't filter out all this stimuli, you will become overloaded. And that's what happens with many Lyme patients. And that's one of the reasons why some Lyme patients get so anxious and they feel overloaded or like they're going crazy because they just have poor sensory integration. Many endocrine problems are associated with Lyme disease. Sugars can be abnormal, thyroid problems, and cortisol can be affected. Now, cortisol is the stress hormone, the anxiety hormone. If your cortisol is out of balance, you're going to be feeling anxious and stressed. Ringing in the ears, called tinnitus, very common. And once again, just like the Lyme can affect the optic nerve, it can affect the auditory nerve, which also can impact balance. Cystitis, I will go over in more detail in a minute. Lyme can cause cold extremities, cracking and popping joints, and overall achiness. Next slide, please. Neuropsychiatric symptoms may be the most common of all symptoms of Lyme. Now, Willy Burgdorfer was the scientist who, in the 1980s, connected the dots between the tick, the Borrelia bacteria, and the disease. And in his opinion, he felt that Lyme was a disease of the nervous system. When he used to transfer his Borrelia cultures to maintain them in the lab, he used mouse brain because that was the tissue where the Lyme organism thrived best. Next slide. Now this is a busy slide. I won't go through it all in detail, but let me talk to you a bit about some of the more common problems associated with Lyme. Brain fog, almost universal, very common in Lyme patients. Now, brain fog is defined as slow, weak, or inaccurate thinking, very poor short-term memory, confusion, disorientation, difficulty concentrating, forgetfulness, lack of mental clarity. It's been described as your thoughts are swimming through maple syrup, or there's a wet blanket laying over your brain. In my personal experience, when I recognized that I had brain fog, I was driving down my street going to the post office, a street that's not busy at all, that I have been driving on for over 20 years. I got to the T intersection, and I couldn't remember if I needed to go left or right on a road that I've been on many times going to the post office. Fortunately, I knew enough to know that that was abnormal and that I shouldn't be driving. But brain fog is common in Lyme patients and can be quite debilitating. Pain, very common in Lyme, especially headache. Paresthesias, also called pins and needles, very common. Bell's palsy, as I mentioned, can affect salivation, tearing, the ability to blink. Actually, Bell's palsy in association with Lyme might be more common than the erythema migrans target lesion that we hear so much about in the media. Now, there's a typo on this slide. It says hyposensitivity. It should be hypersensitivity. And I already talked to you about being so sensitive to the senses, the stimuli, that the patients don't want to wear clothes, brush their hair, brush their teeth. It's just too much stimulation for them. Balance issues, very common in Lyme, as is ringing in the ears. Fasciculations, which is twitching, common, often seen around the eyelids. My son's eyelid twitched 24 hours a day for over a year before we made the connection that it could be due to his Lyme disease. Now, there are a lot of cognitive deficits associated with Lyme. Many school kids have a lot of problems organizing, making decisions, doing abstract thinking, thinking logically. And this also can affect their executive function. Once again, the working memory is very impacted. They lack mental flexibility. They can't multitask. They can't decide what to do next. Even if they're able to complete a task, they don't know what to do next. And these could be things that they had been doing for years. When all of a sudden they're debilitated by the Lyme disease, they no longer have this ability. They can't self-regulate. They have trouble with focusing. They can't remember instructions. They can't plan. All of this can significantly impact school and job performance. Next slide. Now, there are a number of psychological signs and symptoms also associated with Lyme. Anxiety, almost universal in Lyme patients, can be extreme. Irritability. We all get irritable when we're sick, but this type of irritability is very severe and much more than one would expect in just a usual flu-like syndrome. Emotional lability. People can cry. There can be emotional outbursts. They can be very much overreactive to very little stimulus. There can be a lot of anger issues. Once again, some of these problems are not just associated with Lyme, but can be associated with some of the other tick-borne illnesses as well. Depression, obsessive-compulsive behaviors, panic, changes in personality, impulsivity, alterations in mood. These patients can be very sensitive to criticism and very defensive. Many have issues with denial. They can be confused, they can use bad judgment, they can be irrational, with uncharacteristic behaviors. There can be unusual sleep patterns. People with Lyme can either sleep 23.5 hours a day or have trouble sleeping. Sometimes both of these things can manifest in the same person at different times. Nightmares can occur. Next slide. Often it's hard to distinguish between what is psychological and what are neurological symptoms. And an individual Lyme patient might have some of these symptoms, all of these symptoms, or none of them. Once again, these presentations can come and go. They can flare and remit, wax and wane. And these kinds of flares can occur over hours or days or longer. The patient can appear fine 1 minute, but be totally debilitated the next. So one rule of thumb that I use is if the symptom does not respond to traditional therapies, for example, if a person is depressed and they're not responding to what might be the usual approach in Western medicine, then they might consider that there might be an underlying infectious process that's causing the problem. And unfortunately, ticks carry many diseases, and the presence of co-infections can make these problems much worse. Next slide. Just briefly now, there are a lot of gastrointestinal problems associated with Lyme. We know that there's a lot of immune system response located in the gastrointestinal tract. And we know that Lyme affects the immune system and that the immune system affects Lyme. So it's not surprising that we would see a number of gastrointestinal problems. Reflux disease, common, nausea, vomiting, diarrhea, difficulty swallowing. Some patients feel that they're obstructed, that their food isn't moving through properly. Next slide, please. Just a minute here on interstitial cystitis, because it relates back to the difficulty in identifying these organisms. Now, most women are familiar with urinary tract infections. These infections usually present with an urgent need to avoid, a need to go to the bathroom more often, discomfort, and there can be red and white cells in the urine. In usual urinary tract infections, they do a culture of the urine. They usually find something like E. coli, and it usually responds to routine treatment. Except that cultures in Lyme patients or patients with interstitial cystitis never show anything because you can't find what you're not looking for. The Borrelia burgdorferi is such a finicky organism, as I mentioned. It doesn't grow on these routine cultures. The routine cultures are designed to grow out the usual suspects. But when they assess these patients in a more definitive way, many of these people have the Borrelia pathogen that causes Lyme, and that could explain their symptoms and why they've been treated unsuccessfully for many years. Next slide, please. Now, I just want to take a few minutes to use some of the principles of evidence-based medicine to dispel some of the common myths about Lyme disease. First of all, one of the myths is that only deer ticks can transmit Lyme, that the tick has to be attached for 24 hours to cause disease, the bullseye rash myth, the two-tiered lab testing myth, and the short-term treatment myth. Next slide. The first myth is that only deer ticks can transmit disease. Next. Well, it's not just deer ticks anymore. If you look at the left of this slide, you see the Pacific or Western black-legged tick. The deer tick in our area that we worry about is the plain black-legged tick. On the right is the lone star tick. I think that white splotch is supposed to look like a star. It looks like a splotch to me, but the bottom line here is that you never trust any tick. There is even suspicion that some of these diseases can be transmitted through the bite of a dog tick. But at this point, keep a very high index of suspicion. Don't trust any tick. Next slide. If you wonder why the tick is so hard to remove, this is a image of a hypostome. You can see that this is part of the tick's mouthpiece. Once it goes into you, it's going to go in very easily like a fish hook, but it's going to be very difficult to pull out without taking a chunk of you with it. Next slide. The erythema migrans, a rash myth. Erythema means red. Migrans means moving. So you have this moving red rash, and it often looks like a bullseye or target lesion. And many doctors will not treat Lyme disease unless the patient has a bullseye rash. Now let's look at some of the evidence around that myth. Next. This is a classic target lesion or bullseye rash. You do not need to have this type of rash to have Lyme disease, but in my opinion, if you have this target lesion, you have Lyme disease or something very similar to it. Next. This is a more common rash associated with Lyme. This is the oval maroon rash that is not a target or a bullseye. Maybe 20–30% of patients have this kind of rash. Maybe 10–20% have the target or bullseye lesion. Next. This is the most likely rash seen with Lyme disease. And as you can see, there's nothing on this slide. Most patients don't even remember the tick bite, and most patients have no rash. So if you're waiting to see the target lesion or the erythema migrans bullseye, you're going to miss at least half the cases. Next. The attachment time myth. In August of 2013, the Centers for Disease Control and Prevention held a press conference announcing that there were 300,000 new cases a year of Lyme instead of the 30,000 cases that they had been saying for years was how many were being reported. On that day, the medical correspondents from NBC News said that there wasn't any need to worry if the tick hadn't been attached for 24 or more hours. So let's just examine the evidence there. Next. Tick-borne diseases can spread after very short attachment times. We know that after 72 hours, that transmission of a pathogen from an infected tick is about 100%. And the longer the attachment, the more likely the transmission. Next. So while the likelihood of transmission gets lower with shorter attachments, it doesn't go to zero. And we have many case studies where infection has spread in very short order. And in Powassan encephalitis, which is another tick-borne illness that I'll talk about in just a minute, we have documentation that this infection has spread in about 15 minutes. Now, of the hundreds of Lyme disease cases that I know, not one person had a 24 or more hour attachment. Now think about it. Next slide. If we do a little experiment now, if you look down at your wrist and you saw a deer tick attached there, what would you do about it? Well, if you're sane, you would remove it. And then, in a couple of days, when you went to your doctor with a flu-like syndrome, and the doctor said, "Oh, how long was that tick attached?" Of course, you brought the tick with you and a little piece of cellophane tape to show the doctor. You said, "Oh," very proudly, "I got it right off as soon as I found it." And the doctor would say, "Thank goodness, you can't have Lyme disease because the tick wasn't attached long enough." Well, that just doesn't make sense. Most people don't remember a tick bite at all, and many of them have been shown to actually have Lyme disease. Next. Now, that 24-hour myth came from mouse data, and it gets cut and pasted into every media story about tick-borne diseases. Now, the medical correspondent from NBC did not investigate that data herself. She had some intern look it up on Wikipedia, and it came up on her teleprompter, and she just read it. So just because something is repeated over and over again doesn't make it more valid. Lyme disease can spread in much less than 24 hours, and who would take that risk in terms of allowing the tick to stay there for more than that time just to show that you can't get infected in 23.5 hours. Next slide. There is a big myth that has caused considerable damage about lab testing for Lyme. Now, many insurance coverage do not cover Lyme treatment if the patient does not have positive ELISA testing. One group, the Infectious Disease Society of America, recommends a two-tiered testing system. You have to have a positive ELISA test to be able to move forward to have the still inadequate but better Western blot test. Many patients are told that they do not have Lyme disease based on a negative test when they do in fact have the disease. Next slide. A negative lab test for Lyme disease is meaningless. A positive is likely positive, but there are many, many reasons why a negative can be negative. For example, when my son first got sick, when we went into the ER, I said, "I want him tested for Lyme." Well, they tested him. That test was negative, but at other labs he was very positive, because it takes weeks, months, maybe years for some of these antibodies to form against the antigen proteins of the Lyme bacteria. So insisting on a Lyme test hours after the bite is probably going to show a negative test, even if the patient clearly has Lyme disease. Now, the Centers for Disease Control, the NIH, and the FDA all agree that Lyme is a clinical diagnosis, which means that the physician needs to look at the history, the physical, and review the systems, and if the pieces fit, the diagnosis is made. You don't need a lab test to make the diagnosis. You just need to have the courage of your convictions. Next. So, although I say never in medicine, in this case I will say never. Never, never rule out Lyme disease on the basis of a negative lab test alone. You have to treat the person, not the lab test. Next. The short-term treatment myth. Next. Short-term treatment works great in maybe half of the patients, But what about the rest of the people? As I mentioned, probably 30 to 40% of the patients have persistent, ongoing, or chronic symptoms of Lyme, and maybe 10% are totally debilitated. Next. So my treatment philosophy is treat the person until they're better. Plus I like a nice cushion on the end of that treatment. This means that they may need combination therapy, not single antibiotics, for extended periods. One thing we do know about Lyme disease is that the longer the time between the initial infection and appropriate treatment, the less chance there is of a good outcome, and the greater the need for aggressive long-term therapy. Next. There is hope. I must say, my son had a very severe flare about 18 months ago. He was left significantly impaired. Got a call on Thanksgiving morning. He was too weak to walk across the room. He essentially laid there until we drove the 12 hours out to Purdue to pick him up. But as I said, there is hope. He did receive intensive treatment with appropriate antibiotics for a sufficient period of time. He is now essentially, in my opinion, cured with little or no residual deficits. Next. It's not just Lyme disease anymore. We have to be very cognizant of co-infections. Ticks carry many pathogens, and it's hard enough to diagnose and treat just Lyme alone. When you start mixing in these other things, it can become very difficult. Next. I'm just going to go through a few of these because it's important that you're aware if you're being treated for Lyme and you're not getting better, or the doctor says this is the worst case of Lyme disease I've ever seen, you may have co-infections. Now, Babesia is a very common co-infection in Maryland and the surrounding area. You can see Maltese crosses in the cells under the microscope. It can cause rigors, sweats, high fevers, anemia, air hunger, bloody urine. Babesia is the source of what's called red water fever, which wiped out herds and herds of cattle in Texas and still decimates cattle herds Mexico, in Africa, South America. Unlike the human response to tick-borne illnesses, when Babesia was found to be wiping out the cattle herds, the veterinary community, along with the cattle ranchers, got together and put into place a number of very successful programs that controlled the tick population. We don't have problems with red water fever anymore in Texas, so those programs have been successful. Unfortunately, now Babesia is in the blood supply and is known to be gestationally transmitted. So if you're going to get a blood transfusion, you might want to make sure that the blood that you're receiving has been tested for Babesia. Next. Rocky Mountain spotted fever can have a pinpoint rash, but the rash may be delayed. The point here is you need to be treating this if you suspect Rocky Mountain spotted fever before any lab confirmation comes back. Next. Bartonella. Bartonella may be more common than Lyme disease as a tick-borne pathogen. It's really a mess in terms of what is Bartonella, what isn't Bartonella. Joseph Burrascano, who is a tick-borne illness specialist, calls the organism that is transmitted by the tick, a Bartonella-like organism. We don't know if these are all the same as the ones that cause the tick-borne disease versus the ones that cause cat scratch fever, etc. So we're still struggling with that. Bartonella can be transmitted by ticks, fleas, lice, and flies. And some of the distinctive features of Bartonella include severe neuropsychiatric symptoms. If you see a patient that's lashing out or has a lot of rage, think about Bartonella. Next. Powassan fever, or viral encephalitis. This stuff is very scary because it's very currently in the news. There have been recent deaths in New York and New Jersey, but you can't find what you're not looking for. Because this is a virus, it does not respond to antibiotics, and there's a 10 to 15% mortality rate. Even more frightening, about half the cases leave these patients with permanent neuropsychological damage. Next. Let's just briefly talk prevention. Next. Ticks like warm, moist areas, not too hot, not too dry. Unfortunately, Maryland, Delaware, Pennsylvania, New Jersey, New York all have this kind of environment. Next. They like the border between the lawn and the woods. They're not crazy about the grass itself, but they like the tall grass along the edges. Next. Next. You're going to want to monitor all the nooks and crannies about every 2 to 3 hours. Forget that 24-hour attachment time. You're going to be wanting to look much more often than that. Next. Just want to take a second here to talk about how to remove a tick. I get calls and emails just about every week with people telling me the latest and greatest way to remove ticks. The latest was a man who takes a plastic drinking straw, puts it over the tick, and then sucks the tick out of the bite site. That seems a little unpleasant to me. You should not use nail polish remover, Vaseline, lighted matches, Caro syrup, any of those things, because what will happen is the tick will back out if you use those kinds of methods, but the tick often at that time also regurgitates its stomach content. So not only do you have the pathogens that are in the saliva with the potential to spread disease, you now have the contents of the gastrointestinal tract able to cause disease. Keep it very simple. I like slightly curved needle nose tweezers. Grab the tick as low as possible at the attachment site. Don't squeeze it, twist it, jerk it, crush it, or puncture it. Just pull back with a slow and steady force. Wash the area with soap and water. Save the tick in a plastic bag, jar, or wrap it in cellophane tape. And very importantly, look for other ticks. People get so discombobulated when they find one tick, they forget to check to make sure there are no others on the patient. Next. Prevention is the key, and education is the best prevention. Hopefully I was able to share some information with you this evening that might be useful to you. Next. Thank you all, and I'm going to give it back to Candace at this point.
Well, thank you very much, Dr. Spreen. You're a wealth of information, and there's certainly a lot to take in with what you've shared with us tonight. So we would like to open it up for questions. And again, type your questions into the box on the right. I see we have a couple already there waiting for you. We'll start with this first one. Could a lab test come back a false negative if the patient has been on an antibiotic or for another issue, like for sinus infection or something?
You would worry about the patient being on an antibiotic and affecting the results of the test, more so if you were getting cultures done. The antibiotic is not going to affect the forming of antibodies against the protein antigen in the pathogen that infected the patient, unless, of course, the antibiotic is being given as a preventive measure. For example, if the person was bitten by the tick and essentially started immediately on the antibiotic, and the antibiotic was able to eliminate the pathogen right off the bat, then it would be less likely that antibodies would form. So only under those conditions, unfortunately, our biggest problem is that people aren't treated, not that they're treated too soon. So I would say that it would not be a major concern. I do prefer, I'm not a big believer in the antigen antibody tests. They miss at least half the positive cases. If you're initially bitten, I prefer people consider getting a blood culture drawn.
All right, thank you. Another person asks, she states that her daughter has had Lyme for 2 years now with brain lesions. Is there anything that will help her brain fog?
Well, she needs to be appropriately treated with antibiotics that cross the blood-brain barrier. Not all antibiotics do that. For example, doxycycline doesn't cross the blood-brain barrier very well, and other antibiotics might be considered under those circumstances. So it's something that she's going to want to be treated with the right combination of antibiotics for an appropriate length of time, which if she's had Lyme for 2 years, it's probably going to be treatment that probably is going to extend over months. As I mentioned, not all antibiotics cross very well, and she may need a combination of antibiotics to actually sort out the problem. Unfortunately, brain fog is one of the symptoms that is the first to appear and probably the last to disappear.
Okay, thank you. Does stem cell treatment help chronic Lyme? Have you heard of that?
Well, there's been some speculation about that. I don't know if there has been any conclusions drawn. There's a lot of talk out there about a variety of therapies that are being tried. My usual thought is don't be the first to jump on the bandwagon, nor the last. Under the circumstances, I will continue, and I suspect that the person who asked the question will continue to investigate that, but you would have to find a doctor that would know how to best implement those techniques.
All right, thank you. You mentioned that Borrelia passes through the placenta. Have you seen cases where the child was infected from the mother?
Oh yes, there's a number of cases like that. We have documentation of babies being born with the erythema migrans rash, and there could be no possible explanation for how that child got that rash aside from gestational transmission. Now, there has been some work compiled that describes treatment of pregnant women that are infected with Lyme and how best to avoid transmitting that onto the offspring. But it's something that you would have to have a physician who's cognizant of the importance of treating the mother. There's also documentation of Lyme being transmitted through breast milk.
All right, good to know. Okay, switching over to this, what is the time frame for a bullseye rash? How soon after a tick bite will you see it, and how long does it persist?
Well, we don't know, since the majority of patients don't remember the tick bite. There are some people who think that the rash usually appears within about 3 days, 3 days to a week. That would probably be the most common clinical course, but there are other cases that suggest that it could be weeks or months before that rash appears. Now, is it really months before that rash appears, or was there another tick bite somewhere along the way that caused the rash to appear? We're not sure.
All right.
But the bottom line is, if you see the bullseye, then you have the Borrelia, you have the Lyme. Unfortunately, I've heard recent cases where the patient had the bullseye, had positive ELISA and Western blot testing, had the deer tick in the jar, and the doctor would still say, I don't think you have Lyme. Now, I don't know what else these patients could do, or what other hoops they could jump through to convince this physician, but under those circumstances, I would consider getting another opinion.
All right. Once the Borrelia forms biofilms or burrows into the joints, can the right combination of antibiotics reverse this type of damage?
Yes, I think so. Now, you say reverse this kind of damage. Sometimes if the symptoms have been around for a long time, some of the consequences can be permanent. For example, if there's scarring in the tissue or damage to the heart or whatever, some of that may be irreversible. But in my opinion, yes, there are certain things, there are certain drugs that can bust the cysts. There are certain drugs that can penetrate into those intracellular spaces or into the tissues. And there are treatments that can be used to disrupt the biofilms. Now, this is, as I mentioned, a very new field. Yes, dentists have been aware of biofilms for a while, but we're just starting to understand the association of these biofilms with systemic diseases. So we're just learning how to disrupt them, and but there are treatments. There are a variety of things that are being tried at this point that have been successful.
Okay, thank you. There are a number of people that want to know if your son saw a Lyme literate doctor and how your son got better.
Well, initially, as I mentioned, the first half dozen doctors that he saw, including an infectious disease specialist, had no idea what to do with him. I did, through total luck, connect with the Lyme Disease Association of Southeastern Pennsylvania, who set him up for an emergency appointment with a physician who understood Lyme and co-infections. He was treated very aggressively for 6 months and essentially saved his life, although the treatment was probably still stopped prematurely because he was still somewhat symptomatic when the treatment was stopped at that time. He did have a severe relapse about 18 months ago. It was very debilitating in terms of his ability to think, his ability to accomplish tasks, his ability to understand complex things. Now, he is a graduate student in rocket science, so his his program is pretty taxing, but this is a kid who used to be able to study 20 hours a day, 7 days a week, and now he couldn't focus for more than 10 minutes at a time. But we did connect him with very aggressive physicians. He's been on a very intense program now for 18 months. He has a follow-up appointment in a few weeks, and in my opinion is essentially cured. I think that there will be very little residual effects. He did have cognitive testing done at the beginning of this treatment regimen. He'll have a follow-up cognitive test just to see if the results are documentable, and we will likely publish that when we get those results. But he's no longer having to sleep 20 hours a day. He has energy. He can complete his tasks. He can do the complicated thinking that he wasn't able to do when he was in the depths of his Lyme.
All right. Very good. What tests, somebody wants to know, what tests do we ask for in the case where the attending physician is not receptive to a request for a test for Lyme disease?
Well, you explain to them that Lyme is a clinical diagnosis. In the Delaware Lyme Disease Task Force now, we're working to pass legislation that will allow physicians to make the diagnosis without lab testing. You can get the ELISA and Western blot, but there are so many false negatives with that you're better off flipping a coin. The retrospective meta-analysis that have been done, even by the people who are the primary advocates of the ELISA and Western blot, suggests that between 20 and 90% of the cases are missed. So those are not my favorite tests. The test that I prefer is the blood culture. Now, very few labs actually do that correctly. There are labs that do have validated testing and certified testing, and I mentioned those in the book in Chapter 18. I'm not sure if I'm allowed to give the specific lab name on this webinar, but I prefer that. I think blood cultures or cultures of biopsy tissue are the way to go.
All right. And actually, if somebody does have a question about that, they can email me, and I'll be happy to discuss it further.
Okay, great.
Okay, I think we have time for one last question. I'm sorry we won't get to all of them. It seems like Lyme covers every symptom in the book. How can doctors make a clinical diagnosis if the blood tests come back negative?
Well, they need to look at the history. They need to look at the physical exam, and they need to look at the review of systems. Once again, I spell this all out in great detail, but we don't have time for all that now. What they have to have, the most important thing they have to have, is a high index of suspicion and the confidence in their clinical judgment to make this diagnosis without the positive lab test. Because the positive lab test can only support the diagnosis. It can't make the diagnosis. So if you have a patient that suspects that they might have had a tick bite, that has some of the symptoms, they're not going to have all of them, but some of the symptoms, just consider that it might be Lyme disease. Or if you have a patient who has a variety of symptoms that aren't getting better on traditional therapies, then consider that there might be an underlying tick-borne infection there that can be complicating things. So the difficulty now and what we're struggling with in Delaware is getting the healthcare providers educated enough so that the patient doesn't have to come in and say, hey, how about a blood culture? Or, hey, how about treating me with a combination of antibiotics? How about treating me for longer than 10 days? We're trying to get the healthcare providers as educated as some of the patients.
Right. In fact, I had the same issue with both of my sons when I took them for these strange symptoms that they had right after the two of them and my husband were all bitten at Cub Scout camp. And the doctors just outright refused to give them the blood tests. And I kept taking them back. And then they came up with all sorts of other diagnoses from things like ADHD and junior rheumatoid arthritis and, all sorts of things. And, we knew this isn't right. And actually, that's when I sought out a Lyme literate doctor, which there are doctors that are out there.
There are doctors that are out there, and there are some great doctors. And if you're having trouble finding somebody, contact your local Lyme disease support group, like Candace's group, or some of the other in your local area, and they can usually connect you with somebody who is better able to help you than the first 6 doctors that my son saw.
Right. Absolutely. I did want to quickly mention your book, because after people hear you speak, a lot of people have asked me when I've had you come and speak for us before about your book. And this is what her book looks like. It's perfect for physicians. There have been many physicians that I know and some of my own that have purchased the book because it is comprehensive. It's almost 900 pages?
I think 830 the last time I looked.
And but it's also great for folks like myself who are looking for answers. There's wonderful explanations and easy to understand explanations in there, as well as alternative treatments and things like that. So it's really good. And I put this in on my own because I believe in the book myself, and I have it, so I know folks would like to know. But I want to thank you, Dr. Spreen, for taking your time, especially I know we've gone over time, but thank you very much for sharing all this knowledge with us. And I want to thank the attendees for attending tonight. We hope you enjoyed this session. Watch our website for announcements regarding a prevention webinar. I really want to put that out there because prevention is the key. I mean, to avoid all of this mess and all of these symptoms, let's prevent it in the first place. And finally, I'd like to encourage everyone attending to take a small piece of the information that you learned tonight and share it with someone. Let's beat this Lyme together. Thank you very much for attending, and we hope you have a good night.